We will begin with this eighth session for today, the symposium on alcohol-related liver disease. May I invite Dr. S.K. Tyagi, Dr. Ajay Kumar, Dr. K. Rajasekhar, and Dr. Rajiv Jalan to please be the chairperson for this session, INASL EASL and AASLD Symposium.
First, let's start. Good evening, everybody. I think we're waiting for the people to come back after refreshment with tea, coffee. But let's stick to time. We have a very interesting session on alcohol-related liver disease and a very effective and interesting speakers for that. First talk on mechanisms of liver disease progression in alcoholic liver disease. I think we are fed up of talking about non-alcoholic liver disease. Then let's talk about alcoholic liver disease now. And that I welcome Dr. Georgios Szabo. I'm sorry, I'm not sure I'm pronouncing it right. Over to you. She's if I'm not mistaken, she was a past president of ASLD.
That's correct.
Welcome to you. And she comes from Harvard Medical School. Okay. Beth Israel. Okay.
Thank you so much, and I didn't realize that we are coming in right now. I think many people are enjoying the coffee break here. So good afternoon. It really is a pleasure and an honor to be here, and I'd like to thank the organizers for giving the opportunity to talk about mechanisms of liver disease progression in alcohol-associated liver disease. So these are my disclosures that really have nothing to do with the talk today, and those are the people who did a lot of the work behind what part of that I'm going to show you today. So I probably don't need to spend too much time on this slide because you're very well aware of the progression of liver disease in general. The interesting thing is that alcohol use in large amounts can induce steatosis in a very short period of time, even a matter of 1 or 2 days. But the good thing is that once somebody stops drinking alcohol, then the liver kind of goes away and the fat disappears. Over time, of course, with continued alcohol use, this can go into chronic liver disease. And very often, I'm sure that you have that in your practice, that people show up with fibrosis without really recognizing that this progressive liver disease was caused by the alcohol. And of course, once they reach the level of cirrhosis, then increase the risk of hepatocellular cancer and decompensation. And we know that the initial phase is very silent. And in fact, this is the phase of alcohol-associated liver disease that we really don't know how many people have this because it's not being diagnosed, and very often it's not necessarily being recognized by the patient or even by their providers. When we really pay attention to alcohol-associated liver disease at the point when people present with alcohol-associated hepatitis, that is a more severe form. And I would like to also point out that there's a lot of discussion today and in the past few 2 days about steatohepatitis, but really this alcohol-associated acute alcoholic hepatitis is something that's very unique for alcohol-induced liver disease, a phenomenon that we really don't see in other type of steatohepatitis. Another component and consideration of alcohol is the induction of ACLF. As you very well know, even a single dose or very small amount or a small short period of alcohol use actually can induce ACLF in patients, regardless of the etiology of liver fibrosis or cirrhosis. So if you look at the overall picture of alcohol-associated liver disease, then there are multiple components that bring to this very complex pathophysiology. And one initial component is the alcohol and the metabolism of alcohol that causes hepatocyte damage, releasing damage-associated molecules in the liver. But at the same time, as you probably very well know, alcohol also induces a change in the gut at multiple levels. It changes the composition of the microbiome. It increases the permeability of the gut by reducing the tight junction protein expression, for example, and inducing inflammation, particularly in the small bowel. And all of this results in potential translocation of microbial components through the portal vein to the liver, where immune cells such as the resident Kupffer cells or recruiting the macrophages or neutrophils from the bone marrow actually respond to this and reduce and induce inflammation. All of this, of course, is then leading to activation of the fibrotic process, particularly hepatic stellate cells and also myofibroblasts, leading to the continued progression of disease and fibrosis. So if we look at all of this clinically, then typically we think about severe alcoholic hepatitis as a MELD greater than 20 and MELD discriminating factor greater than 32. But really this moderate alcoholic hepatitis and alcohol-associated liver disease is something, it's a little bit of gray area because this is the population that we really don't study too much and we don't have any therapy for. But I can make the argument that these are the patients who then fall off the cliff and show up as severe alcoholic hepatitis. So understanding the factors that really lead to severe alcoholic hepatitis is going to be very important. So what are the key determinants? Well, we know that alcohol use history definitely makes a big difference, whether it's remote or current, ongoing. And also, potentially, there's a difference between the type of pattern of alcohol use in terms of binge drinking or chronic steady use of alcohol. We know that females tend to be more sensitive to alcohol effects and have more liver disease with the same amount of alcohol consumed. Then I'm not going to get into genetics. That's these factors, the PNPLA3, TMBOT7, and TM6FH2, are identified as risk factors, particularly for fibrosis in the case of the latter two, not only for alcohol-induced liver disease, but any kind of, and particularly in steatohepatitis. I'm also thinking about the progression of alcohol disease in the context of other existing liver insults. So any kind of comorbid liver disease, such as chronic hepatitis B, chronic hep CV, hemochromatosis, alpha-1 antitrypsin deficiency, and potentially, of course, MASLD and MASH that can contribute to the accelerated course and faster progression of alcohol-associated liver disease. So when we look at the mechanistic determinants in terms of what are the really components leading to this, there is obviously a very complex picture. So in the hepatocytes and in the liver, there is steatosis, and you heard in the previous talks that steatosis actually causes release of damage-associated molecules, metabolic derangements, causing hepatocyte damage and potentially death. And of course, in this process, reactive oxygen species play a major role. And I just told you earlier that the leaky gut and changes in the gut microbiome, virome, and mycobiome also contributes to all of this. And these factors then induce pro-inflammatory immune activation, impaired host defense, which, by the way, is primarily an effect of alcohol, to really turn on fibrogenesis, and in the later phases, there is sinusoidal endothelial cell dysfunction leading to, and that's linked to some of the portal hypertension that happens in these patients in the later phase. Also have to think about the fact that the liver constantly tries to regenerate. However, this regeneration capacity is as heavily impaired by alcohol. So there is evidence that senescence is caused by alcohol, particularly at the level of the hepatocytes. And I'm not going to have time to show more data about that. We know that regeneration is impaired, and some of this might be linked to epigenetic modulations that were shown to be strong effects of alcohol. And that might be one of the reasons why alcohol, even if somebody stops and starts to use alcohol again, has a profound effect, because these epigenetic modulations already happen and changes the response of the host, and potentially has a higher response and more negative effect of alcohol compared to somebody who never drank before. So between all of these factors, I'm going to dive in a little deeper to one of the kind of unique features of alcohol-associated hepatitis, which is neutrophils. So if we compare the alcohol-associated liver disease and alcoholic hepatitis in particular with other kind of steatohepatitis, neutrophil abundance is one of the unique features. So we were trying to find out what is really behind this whole neutrophil story. And we know that neutrophils typically are believed to be short-lived, which actually is not true, because when they activated, they can live for a longer period of time. And they primarily there to provide host defense against pathogens, but turns out that the same factors can induce neutrophil activation in sterile inflammation, such as what happens in alcohol-associated hepatocyte damage. Neutrophils also have another role in resolution of inflammation that appears to be not going very well in alcohol-associated liver disease. So for this reason, we actually started to use and evaluate the function of neutrophils from patients with alcohol-associated hepatitis. And when we did gene transcriptomic analysis, we found that these neutrophils actually are highly activated, which is really not that surprising. But the interesting thing we found and unexpected is that there was two different populations of neutrophils. And in fact, we identified this unique neutrophil population that's called low-density neutrophils that had a transcriptomic profile of very much exhausted neutrophils that were still alive, but they couldn't do the functions that we would expect from neutrophils. So down here, if you look at, compared to healthy controls, alcoholic hepatitis patients have a big proportion of these cell types. Further, to understand what these neutrophils do, we know that neutrophils have this unique function of called neutrophil extracellular traps, which essentially is neutrophils can spill out their granular proteins and some of their histones and DNA to capture any kind of pathogens that are around it. But they also do this in response to damaged cells. And we found that we actually can find these neutrophil extracellular traps in the liver in alcoholic-induced hepatitis, and also some of these markers actually spill in the serum of patients, and we could detect that. And then we found that the generation of this unique neutrophil population is in a way that alcohol actually stimulates neutrophils to induce these neutrophil traps, and the surviving neutrophil becomes low density because now they don't have those granules and parts of their nucleus. So these exhausted neutrophils, however, stick around in the liver, but they cannot really produce and do the host defense function that otherwise normal healthy neutrophils can do. So, okay, here we go. So then the question is what causes, how is alcohol induces all of this? And that's how we came across with one of the novel mechanisms here that we identified as one of the tyrosine kinases. Bruton tyrosine kinase actually is induced by alcohol. And specifically, we found that binge alcohol induces this activity a lot. So it seems to be that the binge alcohol has a somewhat different, a very much profound effect on neutrophils compared to chronic alcohol use, which I think is interesting because if you really think about your patients, very often the acute alcoholic hepatitis period is kind of preceded by picking up alcohol a little higher dose than before, and these patients become very sick. So what we find is that this Bruton tyrosine kinase activation happens in patients. We also can reproduce it in a mouse model, and particularly in human neutrophils it's found. So then we ask the question, what happens if you inhibit this Bruton tyrosine kinase? And then what we find, again, this is in a mouse model, that by using the inhibitor, we can reduce steatosis, we can induce this netosis phenomenon of neutrophil activation, and all of this is related to an intracellular receptor complex, NLRP3. So one of the other clinical factors in alcohol-associated liver disease and the progression is that we very well know that when patients get really sick and present with alcohol-associated hepatitis, they get very often so sick that they stop drinking alcohol. Yet their inflammation and liver damage goes on and on and on for a longer period of time. So what's the reason for that? Well, I don't think we know. So having that clinical question then brought us to this whole and to made us think about this NLRP3 inflammasome, because turns out that this is an intracellular sensor, and in cells, this NLRP3 inflammasome actually can get out of the cells in a complex that's called S-SPEX. And this is because the adapter molecule X and the procaspase 1 are together. And if it gets out of the cells, it actually can activate inflammation in another cell. So we were interested to see whether these aspects are present in patients. And lo and behold, we found that yes, indeed, they are in the circulation of these patients. And to test whether these actually can induce inflammation, we isolated these specs and found that if we introduce this into a naive mouse, then it induces liver damage, and it also induces inflammation in the liver. So this could be one of the mechanisms by which, even after stopping alcohol, this is ongoing. And we showed that this could be inhibited by NLRP3 inhibitor. So we propose that neutrophils may explain this immune paradox that we see in alcoholic hepatitis, that inflammation is increased, but at the same time there is subclinical immunosuppression, partially due to this dysfunctional low-density neutrophils, leading to impaired host defense. So we heard a lot about MET-ALD, and I just wanted to show you some of the observations that are clinically very relevant. So this is a patient population from the ALCAP-NET study in the US, where we looked at survival of patients with alcoholic hepatitis based on various body weight. Blue, normal weight, green is overweight, red is obese. And it's pretty clear that both the 90 and 180-day survival was reduced in those who had the highest, who essentially were obese. Interestingly, in the same patient population, we find that the highest level of neutrophil activation occurs in those who have the high BMI and also use alcohol, suggesting that indeed these mechanisms have an effect on all the disease. And in animal models, we can show that the combination of alcohol and the MASH diet in MET-ALD accelerates fibrosis, increases inflammation, and reduces hepatocyte proliferation and regenerative capacity. So finally, I wanted to show that alcohol also can induce ACLF. You're very well aware of that. And if we look at an animal model where we induce ACLF in a bile duct ligation model, then a single dose of alcohol essentially induces ACLF with coagulation issues and also with impaired cognitive functions in these mice, and liver damage, of course, and kidney failure. And here again, we find that the neutrophil activation occurs, and some of the mechanism is related to cell death that's happening in the hepatocytes, which is a specific cell death called necroptosis. And if we inhibit that, we can improve ACLF. So to summarize, we find that in the progression of alcohol-associated liver disease, there are multiple factors: the accumulating damage-associated molecules and PAMPs, the induced inflammation, and loss of appropriate anti-inflammatory processes and immunosuppression that accumulates over time, really leading to this decompensation and progressive liver disease. Some of the cellular and molecular drivers are shown here, and data from animal models suggest that actually we can interfere with this and ameliorate the progression by interfering with these processes. So thank you, and I think we're going to have some discussion after.
Thanks, Dr. Zabo, for taking us through this journey of the mechanism of alcohol-induced liver injury. Please join us here because we'll have discussion at the end of it. Meanwhile, if Professor Rajiv Jalan and Professor Tyagi have come, please join us on the dais here. I did see Rajiv somewhere outside. Is it not here? Okay. Okay, then I must. Okay, well, it gives me intense pleasure to introduce the next speaker, Professor Alexander Louvet from Lille, France. He's to speak to us on recent advances. Actually, a lot of us will be interested in understanding what is happening latest in the medical management of severe alcohol-associated hepatitis, and not only that, to also touch upon alcohol use disorder. Over to you, Professor Alexander.
Thank you. Thank you very much for the kind introduction. I'd like to thank the organizing committee and especially Professor Ajay Duseja for the very kind invitation. I'm very happy to be here in this amazing country. So my task today is to try to summarize the recent data on ALCAP and on the management of alcohol use disorders. And I'd like to start this talk by saying a few words about the diagnosis of ALCAP, which is still based on liver biopsy, but most of you know that liver biopsy becomes less and less popular in many countries, for sad reasons, I must say. And many people use the non-invasive NIAAA criteria to define ALCAP. Unfortunately, this classification has many drawbacks. And as an example, on the left part of the slide, you have the results of a recent Spanish study, a cohort of 268 patients, in which the authors tried to evaluate the diagnostic accuracy of these NIAAA criteria. And you can see in, I don't know if I have a pointer here, yes, that the current NIAAA criteria do not perform very well in diagnosing ALK-HEP with a sensitivity of 63%, a specificity of 78%, and an accuracy of 70%. So the authors propose to slightly modify these criteria with the modified one, including CRP. These new criteria were a little bit better, but still a bit disappointing with, in the validation cohort, a sensitivity of 56%, a specificity of 91%, and an accuracy which did not exceed 76%. And this was confirmed on the right part of the slide by an Austrian group showing, again, a sensitivity which is not higher than 72% and a specificity of 82%. So we still need some progresses in the diagnosis. And I do think that liver biopsy still has its place. So regarding the treatment of severe alcoholic hepatitis, we have 5 decades of papers showing that prednisolone improves short-term survival. It has been shown by many, many papers, including this meta-analysis of individual patient data we published some years ago now, showing that a 1-month course of prednisolone taken orally was able to decrease 1 month's mortality, while no difference was seen at 3 or 6 months. Pentoxifylline in this paper was inefficient, either alone or in combination with prednisolone. So since it's not an ideal treatment, we need some tools to identify patients who will take benefit from prednisolone, and among others, the Lille score can be used with the ideal cutoff of 0.45, which helps pick up responders who have a low Lille score and a good survival at 6 months, with a probability of being alive higher than 80%, compared to non-responders who have a high Lille score and a probability of dying within the first 6 months, close to 70 to 80%. So some progresses are still needed. So you probably already heard about this paper Alexander Krag presented yesterday about the fact that some people who have a spontaneous improvement shortly after their admission at the hospital may get rid of prednisolone because this treatment may be futile if they improve by themselves. This was a multicenter controlled Belgian randomized controlled trial, which took 6 years with biopsy-proven ALK-HEP patients. And these patients had to have a MADRS discriminant function greater than 32 and a spontaneous decrease by at least 10% of bilirubin between the admission and roughly 5 to 10 days after. So only 72 patients were randomized and the study stopped, unfortunately, because of lack of recruitment. But you can see that no difference was seen in terms of survival between placebo-treated and prednisolone-treated patients. So can we improve this treatment, which is better than placebo, but not ideal? Well, some attempts were made. There were much hope on targeting IL-1 receptor, thanks to brilliant papers published by Gionji, the previous speaker. There was a strong rationale for using anakinra, which is an antagonist of IL-1 receptor in combination with zinc. And this study was published last year and was stopped early because of an increase in mortality in people not receiving prednisolone, which is a way to confirm the efficacy of prednisolone, by the way. And of note, there were no differences in terms of risk of infection between the two arms. Another paper quite recently published by Dr. Kulkarni is rapid tapering of the dose of prednisolone with 40 milligrams given during the first week, and then a tapering by 10 milligram every week until 1 month. So they showed in this paper that no difference in survival was observed between the fixed dose of 40 milligram per day versus the tapering dose, while the risk of infection seemed to be lower in people receiving tapering dose. Interestingly, for unknown reasons, the difference between the infection started after treatment was stopped, so beyond 1 month. So there is probably some additional analysis to perform to understand this difference. The very new kid on the block is probably the larsucosterol. Larsucosterol is a sulfated oxysterol. The paper has been published in the New England Journal of Medicine Evidence last year. In this paper, patients received 2 doses of larsucosterol, who has many properties, including a role in inflammation, cell survival, epigenetics, metabolism, etc. And steroids could be used in this study based on the clinician's decision. There was no difference in survival between placebo-treated patients and larsucosterol-treated patients. However, in a pre-specified subgroup analysis on only American patients, there were some differences. So there is a phase 3 study which is probably about to start. So let's talk a bit about GCSF, because there are some discrepancies between European studies and Indian studies. This is a meta-analysis published 3 years ago, showing that in people with severe alcoholic hepatitis, while GCSF can bring survival benefit in Indian studies, and you can see here the benefit which is brought by GCSF, while this is not observed in European papers. So obviously we are not treating the same patients, and I do think that we have to work together and gather some evidence to understand why this treatment works in India while it does not in Europe. Since the risk of infection in people with severe alcoholic hepatitis is very high, it was tempting to try to prevent the development of infection by using antibiotics. So this is what we did in a paper which was published 2 years ago. The idea was to add augmentin, given 1 gram 3 times a day, on top of a 1 month course of prednisolone with 40 milligram in all patients. And as you can see here, unfortunately, the primary endpoint wasn't met because there were no differences in survival. The primary endpoint was at 2 months, but you can see that no difference is seen at 1 month or at 6 months. However, the preventive treatment with antibiotics was able to decrease the risk of infection. As you can see, patients receiving augmentin here in green developing less infection than people receiving placebo. And because antibiotics, bacterial translocation, and microbiota is so important, there can be a place to test FMT in these people with alcohol-related liver disease. So we have some data from India suggesting it may work, but I liked Shiv Sarin's comment yesterday when he mentioned in his talk that it's important to reproduce the data. So these data are very interesting, but they certainly need some replication. Besides the very first episode, inflammation episode of related to alcohol in alcoholic hepatitis, some other drivers will drive the prognosis after 3 to 6 months. And the most important is alcohol relapse. So we and others have shown that after a first episode of ALK-HEP, the risk of alcohol relapse is quite significant. We observed in this cohort, this prospective cohort of people admitted with severe alcoholic hepatitis, that the risk of any alcohol relapse was roughly 35% after 4 years. And interestingly, we found no association between alcohol relapse and survival at short term, meaning within the first 6 months. On the other hand, when looking at longer term survival beyond 6 months, there was a major impact of alcohol relapse in people having ALCAP, the risk of dying being increased by 400% compared to abstainers. And not surprisingly, in this paper, we observed that the higher the amount of alcohol consumption after ALCAP, the higher the risk of dying at long term. And this was confirmed by the group of Ramon Bataller on the right part of the slide, with complete abstainers having a much better survival at long term compared to people who relapsed and returned to alcohol drinking. So we have to put some efforts on addiction management and alcohol use disorder treatment in these people, especially because the group of the Mayo Clinic has shown in a retrospective analysis of 135 patients that attending an early rehab program was able to decrease the risk of readmission, of alcohol relapse, and of mortality at long term. So this is something, addiction management is really something which we must encourage, and we are probably not very good at in many liver departments. Especially because we also have some AUD medications. This is a large meta-analysis published in the JAMA 2 years ago, showing that both naltrexone and acamprosate are able to decrease the risk to return to any drinking. However, in this paper, the risk of returning to heavy drinking was only reduced for naltrexone, which was not the case. It was not significant for acamprosate. So we have evidence for this. The problem is, are these drugs safe in people with cirrhosis, with alcohol-related liver disease? And we now have, well, a few data, let's say. So these are the very most recent data published so far on this topic. First, we have the VA retrospective study on close to 3,000 patients treated with naltrexone, Peros in almost all cases. Only 62 patients had any evidence of elevation of liver test after 3 months, and there was no case of delay. So quite good data. In a single center retrospective study by the group of Rohit Lumba, 8 patients with cirrhosis, either child A or child B, were treated with naltrexone. The safety were good, and the changes, there were no changes in liver tests. I forgot to mention that in the VA retrospective study, approximately 15% of these patients with cirrhosis had Child-Pugh B score. And lastly, in a meta-analysis published by my friend Jordi Gratakos and Elisa Posse, compelling 6 studies testing baclofen, acamprosate, and metadoxane, namely the safety profile was very good. This is also a very interesting paper on close to 900 patients. It is retrospective. People received either naltrexone or acamprosate or their combination. All of them had cirrhosis, and they were matched with untreated patients who also had cirrhosis. And as you can see, the survival was better in people receiving either naltrexone, acamprosate, or their combination. And interestingly, the survival benefit was higher in people receiving at least 3 months of one of these drugs. Lastly, I love this paper because I think this is the only paper we have dealing with cost effectiveness in the field of treatment for alcohol use disorders in patients with alcohol-related liver disease. So this is from the group of Jessica Mellinger, showing, thanks to, again, you can see the numbers, the study was very large, and it confirms how AUD medications are cost-effective and cost-saving both, this being extremely prominent for both acamprosate and naltrexone. The benefit was not that important for baclofen, gabapentin, and topiramate, which are, by the way, not approved by the FDA. But anyway, you can see on both on a societal perspective, but also healthcare perspective, that acamprosate and naltrexone are cost-effective and cost-saving. So I'd like to conclude by saying that, well, waiting for new studies, the treatment of severe ALCAP is still based on prednisolone, I'm sorry to say, but, well, I hope I'll have new slides in the next future. So the classical regimen may be adapted, as you have seen, by shortening, by perhaps tapering the dose. And do not forget that alcohol relapse in these patients is a major driver of long-term outcome. And after a first episode, if the patient is alive, the priority must be given to treatment of AUD because we now have some very efficient drug. Thank you very much for your attention.
Thank you, Professor Alexander. Please join us on this. An excellent review on what is happening, the latest in the medical treatment of alcohol-related severe hepatitis. And of course, there's a few words about the alcohol use disorder. Now we go to the last talk of this particular session, following which we'll have question answers. And it's my pleasant duty to invite Professor Ashok Chaudhary from ILBS to speak to us on liver transplantation outcomes in relation to alcohol sobriety in alcoholic liver disease. Over to Ashok.
So at this set, thanks for nice introduction and to the whole INASL. So as we have discussed about the pathophysiology and then treatment, then we'll cover on this most important area. So I'll cover this from outlines. First of all, as we discussed, this ALD, how you have to go for. You see, this is alcohol use is increasing day by day with additional factors. Then the disease, complications, and it constitutes one of the major chunk of liver disease, and this disease has increased nearly double as for the disease as per the SSC deployments. And in fact, in the hall, we are all taking alcohol. If you're not being alcoholic, you can see the per capita consumption of alcohol. If you think of India, we are having 5.27 liter of pure alcohol we are taking per annum. And if you go to the India state-wise, these are the hotspots are there. You can see here, this is the belt here, this is the belt here in northeast and eastern part of India, where the alcohol is a significant amount taken as far as the percentage prevalence is concerned. That means alcohol disease is a burden. In addition, the alcohol per capita consumption is another additional burden going on. And why so? You can go through this alcohol. It is a large study across the globe. We have close to 4,000 database. Here you can see alcohol 1600. Once they get admitted, these are not non-alcoholic hepatitis. So these are the people who are being admitted with alcoholic liver disease non-electively. The mortality is high, transplant is less, and readmission is also on the higher side. That means irrespective of the alcoholic hepatitis, the alcohol is one of the problematic for these group patients. Then if you think of how to go for this, you can see here, if alcoholic hepatitis who has been transplanted, the outcome is okay. Who has shown recovery without transplant, we see often the outcome is good. But those candidates who have not been transplanted and not recovered, there is a huge decline in survival. And you can see here, if the MELD score is more than 25, during the process of transplant evaluation, you can see here we take at least 2 to 4 weeks. These people may not able to make it to go for the transplant. So similarly, as of alcoholic liver disease, you can think of alcoholic hepatitis leading to SCLF. In SCLF, either you put the ARC, you put the MELD or the CLIP score. The definition for the treatment is hardly 7 days because it is the timeline that is going to go for depending on the score, depending on the organ failures, and depending on therapies. So that means this is a alcoholic SCLF is one of the thing where we need to think seriously. And at the same time, despite this, the alcoholic listing, as well as transplants are increasing in US and also across the globe. So how to go for next, my talk is to, if you go for transplant in general for alcoholic in all causes, the transplant decision is taken in by the first year. After first year, the mortality happens only in 20%. If you go for 2 to 5 years, it is non-liver related disease, and after 5 years it is malignancy, coronary disease, infection are the major junk rather than the primary disease. If you think of alcohol per se, you can see the overall survival for alcoholic hepatitis or cirrhosis is good, being transplant. Rejection free survival is good. If you think of having those have been not offered the transplant, or those having relapse, or those having problematic relapse, there is a sharp decline in outcome. That means transplant results is okay, but once the relapse, the risk is more. That means we have discussed that alcoholic has no difference as far as concerned transplant is concerned. Main concern is the relapse. So if you think of ALD in particular, they have survival equivalent close to 25% in first year 5 years develop relapse, and close to one third will develop cirrhosis in 5 years follow-up. And if they develop cirrhosis, and hardly within 1 to 1.1 years, nearly half may succumb to the disease. That means the progression of disease faster if they develop alcoholic cirrhosis in absence of a retransplant. So harmful drinking is one of the factor that causes the main poor outcome for these group patients. So how to think of alcohol relapse? So this you can see definition is varying. Heavy alcohol drinks, you can see here the definition is more than 5 drinks or 4 drinks per week. Non-heavy is less than that. And now they have moved the definition to consider the number of drinks per week, number of drinks more than 7 drinks. And interestingly, now one of the criteria is coming up, that the path test, because this is now one of the sensitive marker for this diagnosis. Even the values of this path has been considered even to categorize them as mild, moderate, or severe relapse also, particularly when you're not able to get a good evidence or the reliable history for the alcohol intake. But when think of alcohol relapse to be considered treatment, it is a spectrum, it is a continuum. That means you have to start from the beginning, that is in the ALD period. Once they have been worked up for the transplant, and then when they are going for the transplant related support system. So we have to act at each point of times, will cover subsequently. So if you think of the strategies for the improving outcome, what is first? So this is what I have few such strategies. Be positive means we have gone through the alcohol recidivism is close to 15 to 25%, and this study is the first study where they have shown in UNOS data that these patients have a high score 39. Steroid can be given in nearly half of the patients, and despite this short, only within 55 days of the index disease, they have gone for the transplant in accelerated trial, and survival is close to 84% at 3 years, and recidive is sustained use of alcohol is close to 17%. So that means you can think of these people to be transplanted when their non-medical resolution is not there. So we can have only 17% relapse, whereas in absence of transplant, 80% is going to have a mortality. Then over the time, things has tends to develop a customized and protocol based. That is, this is initially the pilot study. I think Professor Java was there in this team. So who has been transplanted, being a stringent criteria of follow-ups, which I'll cover, and those has been not having a stringently followed up for a strict abstinence, but psychosocial management, I will come later, has been followed rigorously. So these been the various criteria. They have been considered that whether severe AOD risk, they are committed to have abstinence. These are more of the psychological counseling parameters, and one is the social support parameters. If these things are feasible, then these patients can be considered for the transplant to have a good outcome. Then subsequently, this is the data from ILBs. You can see here we do transplant with a little bit of more stringent as well as family as well as for the social characteristics. And here we are able to have a 203 patients of alcoholic liver disease, When we have gone for the follow-up till 5 years, we have a very limited number of cases, that is close to 9%, and significantly harmful dose is only 2% of the cases. But that is not the story. But most important part is that the predictors of the alcohol related relapse or transplant are if they have the pre-ALT relapse during the disease process, they have taken alcohol frequent episodes despite being diagnosed, if the abstinence period is less than 3 months, if he is a daily alcohol intake, yeah, eye opener, those who are single or a life partner is not there, those having concurrent tobacco abuse, if they received a donation from secondary relative, that means it's very interesting that they have no emotional attachment, he got from a secondary relative a liver, and those who are defaulters on medical follow-up. So these are the peoples are a high risk group where they are prone to develop a relapse. Then the next is the protocol based. This is one important way. Here this study they shows that has the science moved over the periods of no. So this recent publication shows that psychosocial evaluation, relapse risk stratification, and a well-developed relapse prevention plan has been able to develop a good survival outcome for this. And you can see here these peoples have relapse is close to 20% and 25% in both the groups. Those has been in absence of a standardized abstinence period, and those have been personalized care. And interestingly that this you can see here the relapse history was 20%. If you take the path test, you are getting 40% and 27%. That means this test has now increased additional benefit of detecting transplant alcohol relapse. One, those who are on the standard protocol, you are going for the test very often, you can detect very good number of people who are alcohol relapsing and we are not able to get an adequate history. So this is a good thing to be considered, to be integrated into the protocol. And you can see the value of the blood that is less than 20 to 200 or the more than 200 to stratify that he is taking a severe amount of alcohol or no. Then if you are thinking of that way, you can think of putting validated tools. I think everybody is out of this SALT, this HPSS and SDAR scale. So these scales will helpful to you guide whether these people are having a high risk, so that your follow plan can be stringent on this. Then you develop a robust monitoring plan. You can now the time has come up to consider biomarkers. You can see here this ETG in urine. You can able to get a diagnosis of alcohol intake with a good accuracy. You can see here sensitivity is close to 100 or specificity is more than 90% for the last 3 days alcohol intake. If you think of phosphated ethanol, it can able to tell in 3 weeks having alcohol intake and specificity is close to 90%. And the scalp hair or the fingernail, this is a very interesting way. So the scalp hair or the fingernail can able to predict that alcohol abuse is there in previous 3 months or no. So this is how if you put a monitoring system, you can able to detect, you can put a good counseling method for them to prevent this disease. And with this, what happens, you need to have a serial counseling and follow up. It's a very interesting study, it's only live donor syrup from the Korea. What they have shown that the incidence rate is increasing over time, and the predictors for the relapse is abstinence if less than 6 months, those are smoking, or those who have a cadaver liver. That is what I have shown when this live donor program is robust, the second degree relative, or getting a cadaver, that means they have no obligation for the organ or the graft, and hence the residue is happening. And smoking or the tobacco is another additional factor which can indirectly say you that these people may be having alcohol intake, so that you can take actions for to prevent the recidivism. And next important thing is the healthcare professionals. This study shows, this is a survey by the ASLD SIG group, that the AUD, as rightly said by Alexander, that we need drugs are there, but who are using them? Yeah, you can see here the most part of the physicians, they lack adequate training or they're not familiar of the therapies. And side effects also we are not aware of, lack of efficacy. We won't have any time to give AUD management by a clinicians. So this is what part as a clinicians, if a post-transplant clinic or a team of your transplant with coordinators and the counselor and psychologist are there, we can have a look into this to prevent this. So this is what we have discussed about the challenges. The most important is what is happening in our part of the country. You can see here, this is a very interesting data from here. The alcohol intake and the age of onset is very young. You can see 23 years, those having cirrhosis. You can see a cirrhosis is developing with alcohol at the age of 23. And if you think of the disease duration is 12 to 6.8 years, that means they have started their alcohol at the very early age and they develop cirrhosis at a very early age. That is a typical of our Indian scenario. And they are married mostly around 85%, and they have a nuclear family. And you can see this figure, what we see in clinic, a young chap with a small kid, a loving elderly parent, because India believes in the family. So there, and this, the recipient is central to the family. They have a limited income because of the early career, and there is no support system insurance in India for the transplant. So what happens? These people land up with the disease complications. They got financial debridements. And if you go to the clinical presentation, you can see here steroid is only eligible in 12% patients in ACLF or even severe alcoholic disease, and the mortality is close to 44%, and we are not able to give offer therapy. So when this is going on, how to do this? The now studies has emerging of all are there, that survival is getting better. But how to go for? We have discussed the abstinence rule 6 months, recidivism risk, donor, even going for the donor, live donor equipage, and at the same time, do we think it is a life saving? Has shown good outcome despite taking a risk of alcohol. Recidivism only 25%. We have a scenario where there is organ is available, there's live donor is there, and we have strongly and emotionally connected. When so transplant, the 4 members from the family jumps up to give a donor. So whether we should go for or no, then if sobriety interval should think of, we think that this alcoholic are sicker, they are largely non-responders. They have a narrow window up to 4 weeks. Recovery is already happens, those who can happen 6 months survival. Hence, this limited evidence for this sobriety and the rationale is not justified, particularly for these patients, to my perspective. So, if you think of this, you can see here the AGL suggests that it's not solely on the fixed period of interval abstinence. It should be a good period of psychosocial evaluations. So, I'm just covering that these things to be done. So, last, if a patient comes to me, if he's a index or a subsequent, if it is for the index patient, you see the MELD score, you go for the steroid they have been failed, then you need a multidisciplinary board to decide. If is LT feasible, then we have to go for. If no, just supportive care, or we can go for the transplant with a team of psychologists, biomarkers, close follow-up, particularly at least first 2 periods. If is a recurrent episode of relapse and he has failed the counseling or addiction, still here is a window for decision to go for. And this multidisciplinary counseling we need combination of hepatologist, surgeon, psychiatrist to go for this. With this, I thanks my close call.
Thank you, Professor Chaudhary. You can join us on this side. The topic is open for discussion. Yes, Dr. Sandhu.
I wanted to give my comments for the last speaker. You see, liver transplantation, the story of liver transplantation in India. In my city, Ludhiana, I see on an average almost daily 2 new patients who have got alcoholic hepatitis, very severe alcoholic hepatitis. Vast majority of these patients, they have already shifted to me from taking treatment from other centers. They'll end up in the hospitals. They spend a lot of money, and I've seen them going from private wards, 3 admissions, then to the general ward, then finally they die. When these patients are offered transplants, which is the only option left for them, what happens is that first of all, they've already spent all their money in the hospital. When they're told that the amount of transplant, the money that they require for transplant is 25 lakhs.
You can be a bit brief because there are both
Yeah, so what happens is they have no money left. And unfortunately, by the time they reach Delhi for transplant, they have to spend 1.5 months in Delhi to get a transplant workup done, and by then they are dead. So virtually what we need in this country is a very early referral to transplant, and transplant to be done in cities, tertiary cities, not only in the
I
primary
think the
tier
point is well
cities.
taken. We promise you that if a patient comes to us, we won't take more than 1 week. Okay, not 1.5 months. But yes, first,
Yeah.
please
to
introduce
Dr.
yourself and.
Yeah, I'm Dr. Saha from Kolkata. To Dr. Alexandre, is there any role of IV glutathione in acute alcoholic hepatitis?
Glutathione.
Can you hear me?
He's
Yeah?
asking
Okay, good.
glutathione.
Thank you. IV glutathione, I don't think there is an RCT, a specific RCT on glutathione. N-acetylcysteine, which is a donor for this, is different. Several papers to make a short answer. Alone, it doesn't work. N-acetylcysteine alone doesn't work. In combination with prednisolone, it may work. We have one good study, which was unfortunately underpowered, published in the New England Journal of Medicine 14 years ago, which needs replication. And there is another trial trying to replicate this data, which will start in France next year. But for the moment, I mean, it's safe. It doesn't bring any significant side effects. So if you want to use an acetylcysteine, that's not a problem, but the evidence for that is very limited, unfortunately.
But no evidence for IV glutathione.
For an improvement in survival with an acetylcysteine on top of prednisolone. But again, an acetylcysteine alone doesn't work. It has to be combined with prednisolone to be efficient.
Yeah.
Next question.
So my
Please
question to Ashok,
introduce
excellent.
yourself and.
Yeah, I'm Dr. Vineet from Pune. My question to Ashok, a very good talk. So what we find in our transplant units, making a de-addiction protocol is all good, but how do you feel the acceptance of a patient after transplant towards going through that rigorous de-addiction protocol? How do you find it in your center? And have you seen that the educational status play any role, or what are the factors you feel will improve the acceptance of the patient and the family towards that rigorous de-addiction protocol? Because I feel that acceptance feeling is very much lacking even after transplant.
You were rightly said. So most important, the socio status, education and literacy. That is a major part for de-addiction. Second important is that, we have rightly said, that if is the treatment is borne by patient himself or the family, the first relative is getting, they got a emotional attachment that is little bit deterrent. But for having a de-addiction program to be followed rigorously is definitely difficult. But this is needed for first 2 years minimum. So whenever they are coming for routine follow-up to the transplant OPD, to make it a system that everyone should be available with a counselor, psychologist, and you, and most important, the family support. If it's good family. So in our setup, we have only the treating physician, the team of the resident doctors who is there, and the transplant coordinator. So this is how we are able to counsel, and a de-addiction specialist is there. Whenever feel that he needs something counseling, we refer to them. But obviously, we need a more robust protocol so as to follow, and whatever they have shown the protocol, we are less able to follow in our part. But I think that is the way forward we can do.
And
I'm
my
getting
question
some
to
indicators of here. I'm getting some indications that the time is up. May I ask questions from Professor Alexander? You beautifully gave us the pathogenesis or the mechanism of actions. What do you think? Are we close to having a new markers to predict the outcomes in these patients by understanding the mechanism better? And do we have any new targets for treatment to address?
Absolutely, I think it's a very important question, and I think there were presentation yesterday about biomarkers and alcoholic liver disease. That's something that I think there's a lot of signals out there that the many potential new molecules that are related to the pathomechanism. But to get to the point where now we can bring it to clinical applications, we need further complementary studies. I think all of these, the different biomarkers are in a way that validation is required. There are a lot of studies going on with biomarkers, with extracellular vesicles, with microRNAs that are in the circulation. Understanding the importance of that is certainly, it's in the process. In terms of therapies, I mean, even just for my talk, we have some new potential targets I think the limitation is really to convince the industry or funding agencies to actually go on and have their studies further developed and to get more clinical trials into the clinic. I think it's kind of an unfortunate fact that for some reason, I think the industry and maybe our communities in the mindset that we expect that these clinical trials at the very beginning where we are with alcohol-associated liver disease will give us the perfect answer. And I think we have to remind ourselves that in NASH, there were about 200 clinical trials, and we are getting to the point that maybe one is being FDA approved, right? One drug. So in alcohol, we are at the very beginning of this whole journey, and I think kind of all of you need to speak up when you talk to pharmaceutical companies or any kind of funding agencies to bring this to the forefront, because we just need more studies.
Well, thank you very much. I know there are a lot of questions, but I've got strong indicators from the organizer that we need to stop it. We are overstepping our time. And with that, I thanks all the three speakers for a wonderful talk and expect a big clap from the audience from there. Okay, thank you very much.
Thank you, sir.